Okay, we are up and running. So I'm going to try and go through how I look at this X-ray of a young hip, non-arthritic hip. So PACS can be a very powerful tool if you know how to use it. You have the different sort of menus across the top here to get your different angles in your images. So we're going to mainly focus on our angles and our using our circle measurement tools. So I also like to use right click a lot. It gives you the same menu. So first thing you want to do when you look at X-ray of a pelvis, you want to make sure it's rotated well and it's tilted well. So if you look at an X-ray model, for instance, if you're looking at acetabulum on one side, if you rotate it, you can change the orientation. If you tilt it, you can change the orientation. So what we want to make sure is that the tip of the coccyx is centered over the symphysis pubis. And as you can see here, it's slightly rotated. So if you think about the right hip is a little more anterior than the left hip, that would magnify the left hip crossover sign. It would undercall the right hip crossover sign. Additionally, if you want to measure the tip of the coccyx to the pubic symphysis, make sure it's somewhere between 1 and 3 centimeters. This one's right at about 3 centimeters, so it might be a little bit inletized, which again would overcall the crossover sign. So let's look at the right hip more closely. I think I will focus on the right hip in this patient. So when you focus on the right hip, we can zoom in on it some, and what you can look for is a couple different things. One, you want to look for the orientation of the sourceal and kind of get a sense of just how the sourceal is shaped, okay? Number two, you can look at these different lines across here. So the anterior rim or anterior wall, you can follow from the edge of the sourceal down here, and it'll go right across the top of the hip. This right here is called the iliopsoas U. You can look a little indentation in the anterior wall, and it'll come down here into the pubic symphysis, okay? The posterior wall, probably easiest to find it from the back of the ischium. You can see it tracking up this way, and it comes up here again toward the edge of the sourceal. So the sourceal is a weight-bearing dome. In this circumstance, if you follow the actual lateral edge of the pelvis, you can kind of get a sense that this line right here would reference the anterior inferior iliac spine. And so you can kind of get a sense of 3 different lines here: posterior wall, anterior inferior iliac spine. And if you're looking for that on a pelvis model, this is the AIS. Sometimes you can see that it can overshadow the anterior wall. So you want to make sure you understand kind of what the morphology is. So what we're going to do now is we're going to zoom out. I'm going to start collecting our angles. So really important to establish a horizontal and vertical plane of the pelvis. So we're going to go to our angle tool. So if you take an angle and you find the bottom of each teardrop, so the teardrops are very good reference points, and draw a transverse line. The vertical line from here is going to be your vertical line to establish your different angles. So you're going to set that right at 90. If you hold the control button, it will set it at 90. So again, let's look at this right hip here. So we're going to make a perfect circle on the right hip. If you hold the control button down, it will give you a perfect circle. The perfect circle tool will allow you to have a femoral head with a center of rotation here. So this circle here, as you can see, it fits right around the actual femoral head. This is the center of rotation right here. So what we're going to do in order to evaluate the morphology of this right acetabulum is we're going to take this angle tool and we're going to put it right smack in the middle of the femoral head. So you can see that the white line intersects right at the center of the femoral head here, okay? So what we'll do now, this is going to be our vertical line here. We're going to take this, which is going to be our horizontal line, and we're going to set it right at the edge of the sourceal here. So here's a medial edge there, lateral edge right here to establish what our lateral center edge angle is going to be, okay? So you look for the widest part of the weight-bearing dome. Again, you can be tricked on some x-rays where it kind of peters off, or kind of it slants upwards, or you can have an ossified labrum. You're going to establish the lateral center edge angle. Here you can see the center edge angle is 26.6, which is within which is in normal limits. Okay, again, less than 20 would be acetabular dysplasia, and 20-25 would be borderline dysplasia. So at this point, what we can do now is we can make a second line, and we're going to do something called a tonus angle, or an acetabular inclination. So we're going to actually just draw a parallel line to this one. And then make this our 90 again. And so now we've established a horizontal line here. We'll put this right at the very medial edge of the sourceal. So you can find the sourceal right here. From the medial edge, right where that white line peters off in the cotyloid fossa. If you need to, you can get rid of these lines here just by dragging them. And we're going to take this, we're going to take it right down the very tip, and almost the same intersection point of our other line here. So you can see that on this one here, you can see that we have a tonus angle of 8.88, which is less than 10. So 0 to 10 is normal. Greater than 10 is going to be looking like you have got more of a vertical, more of a slope on your acetabular sourceal, and it could be representative of dysplasia. So more than 10 would be dysplasia. If you have a negative angle there, it can be indicative of pincer type impingement. So we can get rid of our circle at this point, and it kind of gives a sense of just sort of the two angles here. So again, lateral center edge angle of 26.6, tone edge angle of 8.88. And so this is not a splastic hip, but it's got some features of dysplasia. So you got to be recognizing or trying to make sure you pick out dysplasia on this AP X-ray, okay? So those are the two main lines we'll do for this one. If you want to, you can actually use your snipping tool by pressing Control Windows S, and it will give you a snipping tool that you can snip this, and you can actually put this into your actual record if you need to. I like doing that because it kind of gives me a sense of what I was thinking when I measured this angle in the first place, okay? So the other things you look for in the AP X-ray, you can look at center, the neck shaft angle. You can look for something called ischial spine sign. So you can kind of see how on this left hip, get a little bit of ischial spine sign. Again, I think on this specific case, it's more representative of the actual rotation, because you can see there's one on the left side. There's not so much one on the right side, which seems to think this is actually probably rotated pelvis. And when it's rotated, when it's internally rotated like this, sometimes we'll undercall a crossover sign where, you can see in this left tip, there's probably more of a crossover sign. And I think it's probably because it's rotated somewhat. Okay. So again, crossover signs are not like, they're indicative of pincer type impingement, but just because you have them doesn't mean you've got some pincer mechanism going on, just something to be aware of. Okay. So we're going to go now to the done lateral. So this is a 45 bilateral, 45-degree done lateral X-ray. I like to get both hips in the same field of view because it gives me a sense to compare the two. And in the postoperative setting, you actually can see what your femorplasty looks like compared to what the native STAP or the femoral morphology is. Okay. So in this one, we can actually zoom in. Again, we'll choose the right side. The right side is the one in question. Again, we're going to use our perfect circles tool right here to put a perfect circle right on the femoral head. Now you're going to be like, well, how do I know where the femoral head is going to be? Okay. I think for me, what I like to do is I like to look at the back side of the femoral head. So if you follow this line right across here and place the circle right along it, it's going to give you a better perfect fit circle. Okay. So you make the circle just big enough to contain the, medial and the inferior aspect of the femoral head. This is the normal sort of quote beta angle, or the inferior angle. What we're really more focused on is going to be up top where the offset loss is. Okay, so cam deformities can be loss of offset. They can be a big bump. What you're trying to figure out is where the highest part of the femoral head is and the lowest part of the femoral neck is, and that will give you a sense of what the alpha angle is. Okay, so again, in this scenario, you've got basically a sort of a pistol grip type deformity, loss of offset, not a huge like cam bump, but more of just the lack of sphericity of the femoral head. So here's our perfect fit circle. Our cam is going to be right here. You can kind of get a sense of what it is. In order to draw a femoral alpha angle, you can do a couple of things. One, you can make a second perfect fit circle on the femoral neck to get kind of an idea of where the center of your femoral neck is. Okay, so let's put this on the center of the femoral neck here, and we'll put this right here. So a double circle is, you can use in the tibia, you can use in the femur, you can use in the femoral neck here. This line right here, this circle right here is going to be the center of the femoral neck. Okay, again, let's get rid of this again. What we'll do now is we'll take this angle device again, and we're going to draw this up through the middle of the head and out to where the ball loses sphericity. Okay, so you can't just do this just haphazardly. You got to make sure you center it perfectly. Okay, so what we'll do again is we're going to click on this circle one more time. It will show us where the center of the femoral head is. We're going to take this and put it right on the center of the femoral head. All right, so here we are, the center of the femoral head. Secondarily, we're going to make sure we're down the femoral neck. Okay, so that's center of the femoral neck. We can get rid of this now. We know we're centered here. Okay, now what we're going to try and do is figure out where the femoral head leaves this circle. Okay, so you can kind of see this whole lesion right here, and you can kind of get a sense of it. And right around here is going to be where we think the femoral head is becoming aspherical. Okay. Now, we don't really need this circle anymore, if you think about it, because what you can do is you can get rid of it. And what you can really do is use this to kind of get a sense of where you think, in a perfect scenario, this person should be rounding out his hip. So I think somewhere right around here is where I'm going to put my line here. So the alpha angle on this hip is 67.80. And so if you think about it, if you look at the angle on the back side of the hip, kind of where you regain sphericity, he's down like the 50s right here. So if you put that same angle here, you can see that's where you really want the depth of your femoral neck cut to be. So we can use this line here really to get a good sense of where you want to establish your femoral osteochondroplasty. So again, we're going to set him right around 67 to be his alpha angle. And we can document that in the chart too. Anything greater than 55 degrees is considered a femoral deformity. And insurance companies really like to see this in order to authorize their surgeries, okay? One of the ways you can look at this, which I think is kind of cool, is you can take, if you think about the radius of curvature of the femoral head, again, we'll make a perfect fit circle here. And so again, the center femoral head's going to be right here. We can take a line here. Let's just get rid of this right here. And this is the radius of this person's head here. So his radius is about 29.2 degrees. So basically every angle you put this in is be about 29.2 degrees, okay? So if you think about how a femoral deformity works, when the radius starts increasing beyond what the acetabulum can accommodate, that's what's going to cause your cam type impingement. So you can see right along this whole area right here, the radius of his femoral head and neck is going to be 31, 32, 33, all the way down to here, 34. So if you think about it, the acetabulum is a fixed volume. If you're trying to shove all this bone up in the acetabulum, you're going to get disease. You're going to get damage within the actual acetabulum. So just keep that in mind. That's how FAI works. You're basically trying to stuff all this bone into the acetabulum, and it can't accommodate that. That's why you get this loss of cartilage, okay? The last one we're going to look at here is going to be the false profile, okay? The false profile is going to be your orthogonal view of the acetabulum. And what it does, it gives you a couple of different things. One, it shows you your anterior inferior iliac spine. So as I point out in the AP X-ray, this person has a pretty prominent anterior inferior iliac spine. Now, it's not below the level of the sourceal, so it's not quite a type 2, but it's pretty darn close, okay? You can also get a sense of the acetabular morphology here in the front. And you can also get a sense of the cam deformity too. So we're going to do another perfect fit circle here. Now, this is a standing X-ray, so you know that where this person stands, the vertical line here that's going to be going straight up and down is going to be basically a perfect vertical line of how his acetabulum sits in space. Okay, so you can use the side of your screen to do that. And what we'll do again, you have to make sure this doesn't go out of the screen, or else you lose your angle. We're going to put this right in the middle of the femoral head again, and we're going to get our anterior center edge angle. So here's a sourceal, and all the way up to here. So the anterior center edge angle in this case is about 35.39. And you can see that's probably a little bit over coverage anteriorly. So he probably does have a little bit of a pincer type deformity, a little bit of spine deformity. You actually get a sense of this of the recess here in the subspine region. So I think if we're going to treat this patient, we got a couple of things we got to focus on. One, I think that, even despite kind of the so much shallow appearance of his hip, I'd probably be inclined to take down a little bit of his anterior rim. Certainly would be going after this cam deformity, and maybe even getting up to the subspine region just a little bit, just to make sure you've got plenty of clearance. Okay, so that's kind of how I look at the X-ray of a hip. And if you get all those angles, and if you do it the same way every single time, you'll find your angles are very reproducible, and you can put those into the chart, and they can help to document for insurance and for research and the types of purposes. Okay, so hopefully that was helpful. And hopefully you can understand kind of what we're looking for. All right, so I'm going to show a quick picture of a hip that's a little bit dysplastic, just so you get a sense of what you want to make sure you recognize and avoid. AP X-ray, not the best tilted. As you can see, we're pretty tight here on the acetabulum, which in fact could undercall. If you think about it, when you tilt the hip back, it can sometimes undercall anterior coverage, okay? Now, that being said, there's still some numbers here we got to look at real closely, okay? Let's focus on the right hip here. So again, let's get our perfect, we're going to use the bottom of the sourceal here. So here's one, or excuse me, bottom of the teardrop. Here's two, here's our vertical line, okay? Second, we're going to make our perfect fit circle in this femoral head. Come right here like this. And so you can kind of get a sense that that's the center of the femoral head right around here, okay? So we're going to take this little line here. Again, we got to shorten this up sometimes a little bit. Go back on 90. Close enough. So we're going to put this in the center of the femoral head, which is right around here, and do our numbers. And again, we're going to follow the sourceal here, kind of watch it peter out. And you can see this is not going to make it up to the realm of normal. In fact, I think our sourceal kind of peters out right around here. So we're going to put it right at 20, right? And then we're going to draw that second line here with that tonus angle. Again, we're going to do a parallel line and do that right there. Tonus angle, put this in the medial as a source seal and put up like this and get a sense of what this is. And you can kind of get a sense of, now we're looking at you have this guy a little more dysplasia. And if you think about it, this hip here is going to be a shallow, low volume socket, lateral center angle of 20. I'm going to zoom in on this for you so we can look at it more closely. So lateral center angle of 20, a tonus angle of this tonus actually probably even higher. It's probably going to be something like 14. We're looking more closely. Okay, so you get a sense of this is a dysplastic hip. The other thing you can look at really closely, if you look at where the anterior rim is in this hip here, you can follow it this way. You can see that this is barely covering the femoral head. Another thing you can look at is you can get a sense of what we call the anterior wall index, and you can draw a pretty fit circle in the femoral head, and you can kind of relate the ratio of the anterior wall, the anterior rim to the overall radius of the actual femoral head. So you can see the anterior rim just barely covers that femoral head. And so you got to be super careful with this if you're going to be looking to scope this hip. This is probably one that probably more warrants a PAO. And again, if this one actually got a nice CT scan and looking at her version, looking at some really different things here. So this was obviously worked up for a PAO. Again, if you zoom back out and look at the false profile on this one, completely different look than that last. If you can see just how much that femoral head's uncovered in the front here, you can put our little our angle coming up from vertical straight down to this line here, and you can kind of get a sense the source still kind of peters out right around here somewhere. So her weight bearing dome, I mean, she's probably somewhere in the 15-degree range anterior synergic angle. Let's get that perfect so we can make sure we maybe 16. Even though you could probably argue that her source seal kind of ends right around here. But you can also get a sense of the upsloping. So this is a shallow, unstable hip. Don't scope this one. All right. Good luck.